Hello, and welcome to today's webinar, How Technology is Driving Transparency in Quality Improvement Programs. Before we get started, I'd like to review a few housekeeping details. Today's webinar is being recorded, and an online archive of today's event will be available a few days after the session. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen on a PC, or Command R if you're using a Mac. You may ask questions at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. And finally, I'd like to remind you of AHIP's antitrust statement located in the handout section at the bottom of your screen. The antitrust statement prohibits us from discussing competitively sensitive information. Once again, we are very fortunate to have with us today Jeff Springer, Shatang Patel, and Dr. Suman Giri. Jeff leads product management, business analysis, and product strategy at Citius Tech, and is a pioneer in the payer technology space, having founded the first payer-provider contract management company in the U.S. Jeff holds a mechanical engineering degree and an MBA from the University of Pennsylvania, the Wharton School, where he graduated as a Palmer Scholar. Shatang is a senior healthcare consultant at Citius Tech with 19 years of experience focusing on payer strategy, business operations, and supporting technologies. Prior to joining Citius Tech, Shatang worked for PwC Health Industries Advisory, serving payer and provider clients. Shatang holds a master's degree in health services administration from the University of Michigan. And Dr. Suman Giri is Director of Data Science at Citius Tech. He is passionate about impact-driven problem-solving through intelligent use of data and design, and is an experienced leader in artificial intelligence and machine learning. Dr. Giri holds a doctorate in advanced infrastructure systems from Carnegie Mellon University and a BS in mathematics and physics from Oberlin College. At this time, I would like to turn the floor over to our speakers. Welcome.
Thank you, Monica, for the kind introductions. So last time we had this audience in this forum, we talked about key trends impacting quality improvement and how they were disrupting the traditional quality management functions, and the concept of efficiency was discussed with various examples. For today's agenda, we want to discuss these key trends that are disrupting quality improvement, but in context of transparency, and how you can create transparency, especially with your key stakeholders, such as providers from a health plan perspective. We'll talk about some concrete examples that we see in the industry of disruption in this context, and then talk about some key takeaways in terms of what health plans can do to ready themselves to embrace these current trends, as well as disruption taking place. Just a quick reminder from our last webinar that we did that focused on efficiency. A couple of key stats that we enjoyed. Number one was when it comes to data science and advanced analytics, 43% of respondents believe that data collection presents the largest opportunity for data science. And the other key takeaway that we thought was interesting was that 64% of respondents, and again, this is an audience similar to yours, believe that the most important priority to generate efficiencies was clinical data integration. And again, this theme of clinical data and clinical value chain is something we'll definitely harp on for health plans as we go through this presentation. So first, let's focus on the trends. And again, we covered these in one way last time, but just to quickly refresh everyone's memory, what are the key trends impacting quality improvement, and what do health plans need to embrace in terms of changes? To start, there are a couple of things that are really important when it comes to these trends. Number one is member experience shift. We know the concept of consumerism and healthcare as retail has led to significant changes in strategies and regulations. A clear example is when you think about measurement year 2023 for STARS improvement and STARS rating, the member experience component and the weightage of member experience is going to be 42%. Compared to 30% in measurement year 2021. The second key trend is the shift in the HEDIS timeline. Getting measures 2 years ahead of time, I think, can help clients and health plans significantly in terms of not only outlining their strategy, that they want to execute over the next couple of years, but also understand what measures really matter as they outline that strategy. The rise of telehealth is again a significant trend, and that, again, COVID is an area, as we know, has disrupted many things in our industry. But the rise of telehealth is certainly being accelerated as a result of COVID. Just to give you a couple of statistical points around that, overall, globally speaking, McKinsey estimates that by 2024, telehealth will constitute $600 billion industry. JAMA recently published the use of telemedicine increased 30-fold from January to June of 2020 in the United States. And finally, Gartner also published some consumer reports that said that there's a significant shift in simple actions, such as seeking medical help virtually, from 5% of respondents doing that earlier in the year. In the middle of the year, 20% of respondents used that technology. Paper-based measures and digital quality measures are another significant trend that are impacting quality improvements. And we'll talk about kind of how digital exchange of information, FHIR-based exchange of information can impact and help you embrace these changes. And speaking of FHIR-based data quality model, it is another significant trend impacting the industry, and we'll also discuss that as an example of how to accelerate data collection using FHIR. And finally, again, another COVID impact, kind of MLR compliance during the pandemic. What are the utilization patterns going to be, especially what we saw in 2020 in terms of a low utilization? Will that happen again in this last quarter and the first quarter of next year? And what will that mean to quality measurement is something to keep an eye on. So considering all these different changes and all these trends that are happening, how do we think about transparency and really drive home transparency to improve our relationship with providers is something we'll focus on today. And this, again, on the right side, you see kind of a clinical value chain. What we have done is, for the sake of this presentation, we have broken it down into 4 key areas. 1 is design, 2 is execute, 3 is monitor, and 4 is engage. And what we are focused on with these 4 fundamental concepts and how they are disrupting quality management is as follows. We'll basically cover 1 example for each of these 4 areas, and those are listed on the left side. For the design component, we'll talk about how to design incentives that really matter and improve quality management for you. From an execution component, we'll talk about modernized data exchange and use of FHIR. From a monitor component, we'll talk about real-time alerts that can be executed as a result of new modernized data exchange. And then finally, in terms of engagement and outreach, how can predicted recommendations truly help you improve the efficacy in those engagements and then continue this overall life cycle of continuous quality improvement. With that, Monica, if you don't mind, could you please cover our first poll question?
Thank you. Yes, in order to see the poll pop up on your screen, go ahead and make sure you're not in full screen mode, and then you will see the pop-up poll to the right of your slides. So the poll reads, to what extent does your organization leverage advanced analytics to drive your value-based contracting strategies? And we have 4 choices. The first one is no AI, primarily back-end queries, spreadsheets, etc. Our second choice is some statistical reporting is used to generate and monitor key metrics. Our third choice is a few AI ML models to help generate insights and guide users. And our fourth choice is AI ML drives everything from contract setup to target assignments and outreach. Go ahead and choose one of the 4 answers. Again, to what extent does your organization leverage advanced analytics to drive your value-based contracting strategies? And we'll leave the poll up while you answer, and I will turn it back to the speakers to continue with their presentation. Thank you.
Sure, and I'll just, while folks are answering, I'll just give one more anecdotal point of view here. Actually, I think we're going to cover that in a second. But what we'll be covering next is an example of design, as I mentioned. And this particular concept we call incentive designer. Suman Giri will be covering that for us next. So before we do that, let me just go back to the poll question here. So overall, 47% say there's some statistical reporting that is utilized today to generate and monitor key metrics. And about 12% say that AI/ML drives everything from contract setup to targets, assignments, and outreach. So as we see, I think there's a fairly good gradient in the industry as far as how advanced folks are in terms of utilizing AI/ML. But at the same time, I think we also see a fairly significant trend. If you look at all these numbers, 47% doing at least statistical reporting, 24% doing a few AI/ML things, and 12% using AI/ML for everything. So that's about 36% where AI/ML is starting to take a significant hold, Jeff. Okay. Thanks all for responding to the poll. And with that, Suman, do you want to talk about our first example?
Sounds good. Thanks, Sitang. Hey, everyone. So I am going to be talking about how technology and data in particular can be leveraged to add transparency to the design process. I will take the design of a value-based contract as one use case under the design umbrella, and as a toy example, I'll keep referencing to is that of reducing readmissions resulting from heart failures. To give you the punchline right away, the crux of what I'm going to tell you today is that data and data science can help you understand the impact of the incentives you choose while you choose them, so that you can pick the ones that are driving the kind of behavior that you want. In effect, if you think of this whole process as a system, data science is helping you shorten the feedback loop based on historic data. Sitang, if you could move on to the next slide. Yep, thanks. So now for any VBR contract, if I am a payer, I will have three major questions that I need transparency around. Number one, what are the outcomes that I am looking to drive? Now, these outcomes could be quality, financial, member experience, and you know the drill. The second question, number two, is what are the metrics I can measure along the way to get to those outcomes? And finally, question number three is how do I motivate my providers to achieve those metrics? So basically, these are the kind of three areas where data science can come in and add a level of transparency and help you make informed decisions along the way. If we could move on to the next slide. Now, there's a lot going on this slide, so I'll just talk through this. Based on the three questions that I just mentioned, so this is where a tool like an incentive designer, right, can accelerate your data-driven decision-making process. For instance, assuming your quality goal is to reduce overall heart failure readmission rates, you want to put a metric in place to ensure that providers are hitting that goal. This one is a pretty straightforward example because you can set a threshold for desired heart failure rates per 1,000. Let's say your goal was instead to reduce medical costs. You can use a framework like this to see whether setting a certain heart failure threshold can actually reduce PMPM costs amongst your attributed member base. By doing simulations on historic data on different threshold settings, you can get to a threshold that a realistic proportion of your provider base are able to hit, and more importantly, B, that brings your overall readmission rates to a desired level. You can also play around with either expected or projected compliance amongst your provider base so you can get a more realistic picture as you construct your threshold. So this obviously is just one example with one metric, but I hope it's clear that you can extend this to structure your whole contract or portfolio of metrics in this way by first aligning on the outcomes you want to drive and then figuring out the appropriate thresholds for different metrics. And by the way, machine learning can automate this process for you by recommending incentive structures for the whole contract based on your desired goals. So as opposed to you having to run what-if simulations iteratively, the algorithm, if you can just feed in what kind of outcomes you're looking to drive, maybe at a contract level, and the algorithm can pick a selection of potential contracts for you with recommended incentives so that you can fine-tune those instead. So it's a great starting point for a more data-driven decision. Now, in addition to this, things like picking appropriate member population for different contracts, figuring out exclusion criteria, optimal risk bands and their impact, etc., are all at their core optimization problems. Right? Today, a lot of this is being done based on domain knowledge. A lot of this is done based on iterative actuarial processes. But these are optimization problems that are very well suited for machine learning frameworks. And data science can obviously drive tremendous value there, both in terms of efficiency and alignment. One more thing to add to this is that a tool like this can also help you figure out what financial incentives you can set for your provider base at a metric level or even at a contract level, with the goal of motivating your providers to hit those metric thresholds. Obviously, incentives that cost more than the desired outcome is worth aren't feasible. So this is a process that can let you understand how to balance your cost with your savings. This way, not only do you have transparency on the expected impact on the specific outcomes you're looking to drive, but also on your financial bottom line. So basically, to summarize everything that I've said so far, data and algorithms can help you make informed choices as you structure your contract by letting you know what the projected impact of your choices are going to be. So it's as simple as that. And the extensions of this are obviously vast, but I think the framework is, hey, if you can use data to understand what your historic performance has been and set thresholds appropriately so that a little bit of your provider base you can expect a little bit of a provider base to shift their behavior, and you understand what the impact of that on your metric is going to be and the impact of that on your financial bottom line is going to be, and that'll help you create more informed and more impactful contracts, or design more impactful contracts. It's as simple as that. So back to you, Shashank.
Right. Thanks, Suman. And exactly what Suman said, in terms of kind of the overview, and again, as we focus on this key aspect of a key theme of transparency, in this first example of contract setup and driving provider alignment, what we covered is how to conduct simulation of goals and incentives, as well as understand kind of the cohorts that you want to study in your population, or with your stakeholders, I should say. Those are the two key objectives that Suman just covered. And as we go through the rest of the presentation, we'll obviously go through all these key objectives that are highlighted on the top across the 4 examples under transparency. The next example will be covered by Jeff. Jeff, I will hand it over to you at this point.
Yep. Thanks, Shadang, and thanks, Suman. So as we think about executing this, and what does execute mean, is driving improvement in your quality measures across your program. So it might be HEDIS, it might be STARS, it might be a value-based program, it could be something operational, financial, and all of these things clearly will have goals as you set them out. But as we think about this, let's also think about this from the provider physician perspective. And so, not surprising, 86% of physicians said that increased requirements for data reporting to support metrics and the business side of healthcare have led to dissatisfaction. So the ones that I just talked about, STARS, HEDIS, even risk, value-based, are from the payer side. So on the payer side, HEDIS has 80 measures, STARS has 45 measures, value-based typically 5-10 measures per contract. All of those things are different groups driving that improvement. You think about it from the provider perspective, they typically have an office manager, somebody in the front office, somebody in the back office. They don't have different groups for this. And then they also have their own metrics, so meaningful use, MIPS, ACO. On the hospital side, they've got JCO measures as well. And all of these things have added to the amount of reporting they have to do in addition to the metrics that they have. And if you think about this from a provider's perspective, 90+% of their revenue still comes from fee-for-service, and they still have 15 minutes to see a patient. And so how much time can be devoted out of that 15 minutes to this increased reporting, these increased metrics that have to be done? Transparency can go a long way towards helping them to get there, but we also have to create efficiencies for them as they do this if we want to increase the number of metrics that they're looking at. So they're already going to be driven by metrics that they have to report on their side for regulatory or value-based purposes. But now payers are coming at them and saying we want to increase metrics across different programs as well. So how do we do this? How do we think about this? One way is bold statement, eliminating chart chase. So if you talk to a physician and you said to that physician, do you know what you need to do when you see a patient? What are the things that you have to talk to that patient around? Large majority of physicians will already know what the questions that they have to ask are. They went to school training to make sure that their patients are well cared for. So the question is, are they getting the right care, or are we not documenting the right care? And overall, it's largely documentation problem that's happening. And so the documentation that payers get is typically from claims. How much of the data from that visit ends up in the claim? Not enough to support the closure of that. So it requires a chart chase event. That chart chase is time, effort from both payer and provider. It's slow, it's antiquated, especially in 2020, even with COVID out there. And so the question becomes, how do we make this more modern? How do we get rid of chart chase for this? FHIR takes a big step forward towards enabling that. So what is FHIR if you're not on the technical side? There's new regulations, the CMS Interoperability rule, that mandates that payers make patient data available by FHIR on the provider side. There are standards where they have to provide, there's a standard called USCDI, where they have to provide a certain amount of data out around those patients as well. So this is a good step forward, but the question is, what can we use of that data to help reach this goal of eliminating chart chase, to create the transparency in the data to close these measures? Because really you're talking about, do I have the right codes? Do I have the right values in this processing? And if we look at FHIR and the things that FHIR can do to communicate around the data that's missing and to help close those gaps, is a huge step forward. So what are the gaps that the provider has to close? The communication around that to the provider. So, hey, I know if I have to close an A1C gap or a CDC gap or colonoscopy, whatever it is, as a provider, you say that, I know exactly what I need to do from the point of care perspective. From the documentation perspective, that's a separate thing. But getting that list of gaps to the provider, step one. Then when the visit happens, how do you get that proof? And that's where the FHIR results coming back can help. And so if we look at a single measure, and we've picked a HEDIS measure here, but it's actually representative of other measures, certainly of the HEDIS measures that are out there, as well as a large portion of the STAR measures, that we see that the new standards that are coming into place really check the boxes on a huge amount of the data that has to be collected via charts. And so instead of having to go out and collect a chart for this, can you imagine understanding that a visit has happened and you can automate the request and the retrieval of that data through these FHIR requests? So of the 12 fields that are needed for a colonoscopy as our representative sample, 11 can be collected via FHIR. Now, 7 of those 12 are straight from the FHIR USCDI data interoperability standards. So things like your screening dates are in there, your evidence dates are in there, and those make up 7 of the 12. So there's a number of different screening dates for the number of different tests. 4 of the 12 fields can be derived. So the type of test for an FOBT, number of samples, the scope of the screening, results and findings, those are all things that are in the USCDI standards, but they have to be derived. And there's only one field out of the 12 that cannot be retrieved from this FHIR USCDI standard, and it's the hospice evidence date. And hospice is not something that all of your patients will have, all of your members will have. It's a very, very small percentage. So it's something that you can close the gaps on large number of the members through this data exchange with FHIR. And this is true for almost all of the HEDIS hybrid measures. We did analysis of all the measures, and 90+% of all the hybrid measures data can be supported through the USCDI standards. Now, the question becomes, how far does the FHIR regulatory regulation help you to collect this? So it goes a long way, but it's not all the way. So you have to do a few things on top of that, like person identification, connecting to the providers to do this outreach. But the standardization of this data into these formats, the regulatory requirement to publish this data, really we can start to see a path to eliminating chart chase for large portion of the members that are out there. And that's a huge effort for both payer and providers. So we go back to the statement that providers are being overwhelmed by these standards. How do we help them? We help them by automating some of the manual efforts that are out there. And what Suman talked about of improving scores, coming up with broad strategies, if you don't improve the efficiencies, you can't put more stuff as goals out there. And so you have to improve the efficiencies, and that's one of the things that really helps here. So as we look at the data collection for driving efficiency, it's really around two additional things. So you see up in the top right, we're slowly filling in the bubble. So on holistic measurement, the ability to collect this data in a dynamic way. Typically, this data is collected 2-3 months or even a year after it happened. When we go collect the chart from last April, that creates very slow turnaround time, and then accurate data exchange to be able to collect that and do something about it more proactively. So as Shatang talked about, with measures getting released earlier, ability to put these into contracts, if you can't respond to a provider or a member, hey, for this visit you did or didn't get the right care, for months and months afterwards, it breaks the continuity of the coordination that can happen in making sure the right things happen at the right point in time. So as we go on, let's go to our next polling question. And Monica, if you can take us through this polling question.
Yes, thank you. Once again, please make sure you're out of full screen mode by clicking Escape so you can see the poll that has popped up on the right side of your screen, just to the right of your slide deck. And the question reads, how does your organization define its strategy for monitoring care gaps and driving closure? So we have 4 choices. The first choice is a combination of gaps, engine reports, and quality care team or provider network staff. That's the first choice. The second choice is automated outreach, email, fax, portal to members and providers in addition to gaps, engine, and staff. Our next choice is advanced analytics models to identify and action high priority interventions. And our last choice is all of the above. So we have 4 choices then. How does your organization define its strategy for monitoring care gaps and driving closure? And I will turn it back to you when you are ready to share that information for our results. Thank you.
Thank you, Monica. So as people are answering this poll, I'm going to go on to the next section, and we'll do one slide, and then we'll come back to the answers to that so we can see how people are doing that. But as we do this, so we talked about the communication with providers via real-time data sharing via FHIR and other things. But the other thing that we can also see here is more and more digitization of healthcare. And so if we look at the amount of people who are using mobile devices in clinical settings, it's fairly tremendous. So of 500 hospitals and clinics are supporting records on iPhones, on iPads, and it's estimated that 728 million iPhones were used in 2017, and this statistic is clearly a little old, but still represents the scale of which this is being used. And this is just Apple, so we also know that Androids are equally as prevalent out there to get these records. So the digitization really allows for the communication to stakeholders in a much quicker, easier way to get this information into the right person's hands at the right person's time without having to do big enterprise applications on top of that. So with that, we'll go back to our poll that we had, and we'll publish our results here and take a look at what we saw. And so clearly the big one is the bottom, so 42% say all of the above. Let's examine the 2 next choices. So combination of gaps reporting, quality care team, provider network staff. So this is more of an analytics approach. I would say this is fairly common. I actually expected this one to be our highest answer. It's actually very good that the third answer, advanced analytic models identifying and actioning high priority interventions, is equally as popular an answer for that, where automated outreach, email, fax portals is the lowest one to ensure that closure. So maybe some of the models are out there and the analytics are out there, but the real-time piece of this is the last frontier, and that's that second one. And that's what we're going to talk about now. And with the digitization of healthcare, as we see from use of mobile devices and things like that, really can enable that alerting real-time communication. And so we talked about this a little bit before with FHIR, but it starts with understanding what those gaps are. So in a really easy to consume way, patient members coming in to see their provider, what are their gaps, and make sure that in that 15-minute conversation the provider is going to have with that member, because that's typically the practice patterns that are out there, do they know all the right conversations to have? Now, segmentation and prioritization become equally as important in this, and this is where AI/ML can come into the equation to make sure from an outreach perspective you're doing that outreach at the right places and the right time. So it could be who has to go in for a visit, who's impactable, how do you get that communication, and then it's the exchange and generating alerts off of those. Now, alerts is and has been a four-letter word in healthcare at points in time. So if you enter any hospital setting, and I know we're not necessarily talking about hospitals, but if you talk about any hospital setting and talk to the nurses, they will tell you they are over-alerted. In fact, a lot of them turn the alerts off. Similar with pharmacists, I've watched them do their workflows. They just ignore all of the alerts. So how do we create alerts that are actionable? And this is really where AI/ML can help. And the one thing that we've seen in the type of communication that's out there is communication between events. So that coordination of care, the transition in care measure for HEDIS is a good representation of that. It's not the only representation, but it really starts to get that communication going. So we've seen from hospital visits to post-acute or even PCP communication is not 100% or even close to the communication that it should be. So the communication to a SNF or a post-acute home health PCP to do the appropriate follow-up care doesn't always happen all the time. How do you make sure that happens? And this is where alerts are very helpful. So the payer understanding that the visit happened. So members who were admitted, communicating with the PCP to say, hey, this member's in the hospital, and that you should be aware of that, and that there will be a discharge at some point in time, also alerting SNFs, post-acute, home health, for those types of things to make sure the right care is happening at the right point in time. When the patient member is discharged, then ensuring that those gaps get onto provider lists. So how do we make sure that you can send these gaps to provider systems and put them as task lists within their workflows? So as we talked about, there's not a lot of administrative infrastructure for providers, but they definitely have workflows that they drive, they look at, schedule for those things. So getting the right provider to know that they should have this visit, even sending alerts out to the member, the patient, to say, hey, make sure you schedule a follow-up visit with your provider. These are the types of things that this type of communication can enable. So remember, providers are overwhelmed with this stuff. They just want to provide good care. They have to do that within the infrastructure that they have. Automating this communication, getting the member to schedule their visit, getting the front office to schedule that patient's visit for them to say, here's the list of members that have to be seen in a very efficient, easy way is incredibly important. So pushing the FHIR API to say, hey, this member was discharged, creating an alert within that workflow for the provider for that patient is possible. Now, a lot of people have said, hey, I can't add information to the medical record within an EMR. That is definitely true. A lot of the EMRs prevent you from adding information to the medical record. but most all of the EMRs allow you to create tasks within their systems, and those tasks really then become part of their workflow as far as the next steps and the communication around that. And what we've seen is communication with PCPs is not awful, it's not terrible, it definitely drives improvement, but communications with other post-acute providers is very, very poor out there. And so the communication for all care coordination, and care coordination really is the name of the game of improving care across different entities. Really the type of automation here, the alerting to the right people, we're not talking about folks that are already over alerted like your nurses in an inpatient setting. We're talking about people who have to perform care and don't know that they have to perform care around transitions. So with that, we're talking about the segmentation. So who's impactable? So if we're over alerting to somebody who's not impactable, if we're providing those real-time alerts to the appropriate stakeholders in the right way. So for your providers, for your members, making sure that they're consuming this information in the right way. We're talking about right from step one, which Suman talked about, of creating the right incentives for providers. But over these last two sections, we've talked about their ability to consume those incentives. So from a data collection perspective, from a workflow perspective, we have to make things more efficient. One of my favorite analogies around both of these concepts goes back to banking. And so if we look at other industries, everybody likes to compare healthcare with other industries from an efficiency perspective. But when I got my first paycheck, somebody walked around and handed me that paycheck, and I waited in line at the teller over my lunch period. Now I can't tell you the last time I saw cash or even a check, and if I do, I take a picture of it with my app. Today in healthcare, we're still waiting in lines at tellers. We're still collecting paper. So think about every time you touch a piece of paper, even reporting, every time you touch a report out there, it is a retrospective process. It is a slow process. So NCQA, with some of their changes, is trying to speed up the measures, the information. CMS is trying to speed up the communication vehicles with FHIR and real-time transactions that are out there. And now we as an industry have to take their leads, take that ability, and really take big steps forward so we're no longer waiting in line at the teller. So with that, we'll go to our third poll question. I'll turn it over to Monica again.
Thank you. We have our third poll question that is coming up right now. And again, it will appear to the right side of your slides, and make sure you're out of full screen mode to see it. And it reads, how do you collaborate with your providers to improve quality performance? So we have four choices: share quality reports on a regular basis, or share reports and have a provider relations team follow up, or provide granular, customized guidance to key providers, for example, members likely to engage for a given intervention, or number four, all of the above. So once again, please make your choice. How do you collaborate with your providers to improve quality performance? And I will turn it back to our speakers to discuss the results. Thank you.
Great. Thanks, Monica. And as we wait for the results, let me just set up the next section. So the last section we wanted to talk about is the example around engagement. And what this will do is truly bring together everything that both Suman and Jeff talked about in terms of not only the design, execution, and monitoring, but also incorporating some element of efficacy as far as actions are concerned into engagement. Before we get into that, just another industry perspective here. More than 2/3, 68% of physicians believe that when it comes to value-based care arrangements, advanced data analytics tools are super important to truly execute them the way they need to be executed. Let's go back to the poll question real quick and see what the responses were before we dive into the final example. So overall, in terms of how collaboration takes place with providers today, 50% mentioned they use all of the above. That was the highest answer in terms of collaboration techniques. Number two, which is share reports and have provider relations team follow up, was kind of that and number one, which is just share quality reports, were a little tied as far as overall collaboration mechanisms are concerned. Interesting to see that granular customized guidance to key providers did not have any responses. So I'd be very curious how this changes as we progress over the next couple of years. But having said that, let's talk about how we can utilize some of the key components that Jeff and Suman talked about and overall engagement. So when it comes to the precision analytics for targeted quality improvements, what we have done is broken it down into kind of 4 basic steps. And again, a lot of this has to do with the detailed processes can be much more detailed, but these 4 basic steps will help you understand where you are as an organization and where you may need to go as you move through this. So the first one is which providers to go after. And defining that relationship, having proper discipline, onboarding, and certainly agreements beforehand with those key providers. Which providers do you need to influence to optimize your network? And this is all done based on your historical performance with these providers and analyzing that historical performance. The other element of this first piece around relationship and onboarding is also understanding the capability and maturity of those provider counterparts, right? Do they have the ability to exchange FHIR resources and have FHIR servers that you can do that? Do they have the ability to have CCDAs available to you within 24 hours of encounter? I think that capability on the other side is very important to understand at this juncture, and making sure that incentives are put in place to improve that capability and maturity as when it comes to data exchange over time. The second piece is which goals, which incentives really matter. And incentives is a very behavioral component, really catered to an individual. So what is really going to move the needle for that individual to take action and that provider, that specific physician to take action? And this is also based on the conditions that your membership, that are most prevalent in your membership, right? You want to have providers that are there, high-performing providers for the conditions that matter to you. You have to kind of, again, when it comes to that network optimization piece, you want to make sure you have the components set up in your network that adhere to the conditions that are prevalent within your membership. And when it comes to that target setting and goal enablement, combining the two is really what we're after. Third is, how is the information communicated? Are my incentives aligned with the communication channels I'm using? So here we talk about a provider portal as an example in terms of communicating this information. Jeff talked about a couple other examples in terms of how this communication can be advanced and even make it as real time as possible. So beyond just the capability maturity on the other side, what is the willingness of the provider to receive that information on a daily basis? Are they able to action it on a daily basis, or is it better to do it on a weekly basis so they can action it more appropriately? These are all things, the communication piece, the channel of communication, you have to align them to that provider's kind of personality and priorities. And then finally, when it comes to the workflow, and this is where the efficacy components comes in, how do you incorporate the gap closure workflow in a way that that can be smart and can evolve over time? So putting the efficacy and back into the workflow of the actions that you have taken, putting that efficacy of actions back into the workflow becomes extremely important as you think about how AI and ML can truly impact and truly disrupt this functionality. So how does this all kind of come together? What we did is we kind of just laid out a simple graphic, right, in terms of how this can come together. And again, think about all the things that Jeff and Suman also discussed prior to this. And I'll walk you through what this graphic, kind of how this graphic summarizes it. It is very important, first of all, to look at a 12-month period, right, to make sure that you understand and you glean from the various patterns and nuances that happen throughout the year. And this could be because of regulatory reasons, this could be because of strategic reasons, could be various reasons. And the other piece, the other reason why you want to look at it this holistically is also to make sure you can manage your resources and resource spikes accordingly. Because again, depending on the part of the year, those resources can be less available or more available depending on how your organization is structured. The second thing that you need to do once you have that kind of full picture where you are today and where you want to be at the end of the year is truly understand, truly understand and have the ability to do proactive measurement. So not only waiting to do retrospective, but doing as many prospective actions as you can do with your existing technology and identifying where I'm falling short today in terms of gap closure. It becomes extremely important. And then marrying this with the ability to recalibrate goal performance. So again, I talked about whatever actions I took last year, how effective were they? Having that data, incorporating it into my algorithms, and making sure these outputs that the algorithms produce and this informed pathway that is produced incorporates all those efficacy pieces becomes extremely important. And then ultimately, of course, I want to have a more informed, predicted goal that I can achieve as I go through these adjustments throughout the year for various reasons. These adjustments and these recalibrations that take place are important to make this not only a successful one-year effort, but a successful year-over-year effort. All right, so that brings us to the conclusion. So what we, and I'll quickly just cover this and hand it over to Jeff for his concluding thoughts. But what we just covered are 4 specific examples around this theme of transparency and how you can utilize the trends that are going on in the industry today, how you can utilize those trends, embrace them, and hopefully create more transparency with your data exchange partners to truly improve your organization's well-being. And we talked about the 8 specific goals in these 4 examples that are listed on top through data science, through prior adoption, and of course, next-gen analytics. With that, Jeff, any concluding thoughts for our audience?
Take myself off mute. Yes, thanks, Yutong. 100%. So as we think about going back to the first concept of where healthcare is going and some of the key trends that are out there, I think it's very important as I talk to our customers, they all think it's very important that they take a step back and take a holistic view of how to drive this improvement, not just through more efficient processes of what they're doing today already. And I think as we've seen from the audience with some of the survey results, people are starting to invest in and use machine learning algorithms and data exchange techniques that are changing the dynamic of the relationship between the different entities that are involved. And there are multiple entities on the payer side, so you've got probably a quality team, a HEDIS team, a STARS team, maybe value-based teams, so on and so forth. So a number of teams on that side, but then also on the provider side. So changing the way we engage around quality is important. NCQA is driving this, CMS is driving this, and so it's going to take a technology-driven approach, so involving your IT teams to start the investment in some of these areas to really drive the improvement, and then pick priorities. So clearly you can't eat the whole elephant at once. It's an analogy one of my first bosses gave me. You have to take one step at a time. So break off pieces that make sense, that add value along the way, but also build infrastructure to help you drive this improvement. We can see a world where, as I talked about, people no longer touch checks or have to wait in line at tellers, but we're still in that place from a healthcare perspective. How do we identify pockets to really grow and really improve our processes with measures, with case logic, with engagement models that really help both payers and providers? And it's important to think about our partners in this, the providers, and then look to really refine these over time and build a bigger world, a world where we don't have to worry about chase afterwards, where we really can expand and provide the right care, the right communication, both to our provider partners as well as to the members out there in terms of driving their improvements to care. So taking one step at a time, building the infrastructure, clearly the regulatory industry is driving this way, and for the folks who are attending this webinar, we're starting to see that type of thought process as well. So with that, we'll see if there's a few questions from the audience. Looks like we have a few minutes for questions out there.
Thank you. We certainly can address some questions that have come in during the presentation. And of course, to ask a question, go ahead and type your question into the Q&A box on the top right-hand side of your screen and click Enter. And I will turn it to the Q&A session. And would you like me to ask the questions that have come in? The first one reads, could you please expand more on pattern analysis to drive efficiency?
Yeah, so I'll start with this question, and then I'll tee up Suman, who's probably the one that you want to really answer this question from a data science perspective. So efficiency here is really a big term, because you've got efficiency in each of the 4 sections that we talked about. And so right from the incentives of what are the right incentives to drive the right behavior patterns. So what are the measures that can move the needle, but also from a provider's perspective, what do they have the time and energy to be able to consume, to the chases. So which providers can move the needle in terms of more interaction, more involvement that's out there. What are the right things that you can do from a technology investment perspective to do the coordination of care, to have really a real-time feedback, to take us out of that retrospective world. And so as we think about these different areas, there's a number of different patterns that we can do, both pre-contract, during the execution, and then afterwards. So I'll turn it over to Suman a little bit, and he can talk about all 3 of these pieces and talk about some of the things that we're seeing out there.
Sure. Thanks, Jeff. That was actually very well put. I think what we mean efficiency here is basically today, every time we need to make a decision, it is an iterative process, right? And it is not being driven by data, but it's being driven by intuition and established kind of rules, and so to speak. So for instance, if I want to create a contract, there's a set of, let's say, variables that I choose from. And I go back to my analytics team. They tell me, hey, this is what it looks like. Then I look at the numbers, and I go back to them again and say, hey, what if I tweak this one thing? And then it's an iterative process that takes weeks, months, sometimes years. And it's not truly data-driven, right? Because you're not doing what the data is telling you, but you are posing certain hypotheses that have your own biases in them. And then you're trying to make the data fit your intuition. A true data-driven or an optimization framework would just look at all possible combinations, right, using certain mathematical approximations, and tell you, hey, these are the 5 or 6 kind of areas in which you should be looking to maybe structure your contract or track your provider, track your performance, or maybe measure your interventions, whatever the case may be. The general framework is you let the data kind of tell you where you should be adding your intuition, and then you fine-tune it and then make decisions based on that. And that's generally the framework. And as a byproduct of this is your process becomes more efficient. Like now it's no longer an iterative process where you have to go back and forth on certain things. Obviously, there will be some back and forth involved here as well. But this is as I said earlier, it's kind of shortening your feedback loop. So your process becomes more efficient. You don't have to wait until, let's say, the end of the year to figure out, hey, this metric that I set in place or this measure that I set in place to reduce my PMPM cost, for instance, isn't actually doing that. You can use historic data to figure out what are the measures that are likely to do that in the first place, so that you don't have to wait till the end of the year to figure that out.
Thank you.
So that's.
Thank you so much. We do have other questions that have come in. I will jump right to those as well. The second question reads, will FHIR-based DQMs see wide adoption, and if so, when is that expected? So will FHIR-based DQMs see wide adoption, and if so, when is that expected?
Yeah, so Monica, we're challenging you on your healthcare acronyms. Welcome to healthcare. We acronym everything here. And so digital quality measures and the adoption of those. So don't have a crystal ball in terms of the adoption of these, my answer is I hope so. So we saw with meaningful use on the provider side, the use of digitization there really helped to improve the scores and improve the processes and take us out of a chart chase world. And if we're really going to drive improvement in care, we've got to get to a world where we're getting technology to do all of the operational things that are easy and allowing our providers and our members to get the right care. And so I think that that's the world we're moving towards. If we all had a crystal ball on healthcare and determined, when will that happen, I don't think that any one of us will be right if we guessed, but we can certainly see a world where we're moving in this direction. If I combine this with the concept of value-based care and needing to be flexible in terms of the types of measures you're picking and the automation of the calculation of those, I think this conversation becomes the conversation about how do we truly improve care and drive that improvement. So we're not just focused on, 5, 6, 11 measures. So there's 11 hybrid measures, but providers have only 6 quality measures in their MIPS programs, and they're already saying it's too much. So the digitization of these things really can help us to drive a broader scope of these things, allow providers to be physicians, not to be data people, to care for our members, to care for, give high quality of care, but to create the transparency around what needs to be done and what was done. Tong, Suman, anything to add?
No, not on that question. I think that was answered perfectly.
Thank you.
Yep.
We do
So, Monica, one more question, and then I think
just one more that has come in. Would you consider FHIR an extension of HIPAA high-tech from circa 2010? Would you consider FIHR an extension of HIPAA high-tech from circa 2010?
Yeah. Once again, we're giving you more of an education on acronyms. So, interesting question. So I could take this question in a few different directions. So HIPAA high-tech made sure our data was protected. And so in protecting our data and making sure, only the right people could see it and that it wasn't used more broadly, you could actually consider that it put blocks on interoperability. And so as we think about good quality care and interoperability being synonymous and needing to have data exchange, good data exchange with interoperability, you could actually say that FHIR is an extension of this. It's more of a logical extension in my head of how do we improve care? How do we improve the quality of care? And in the healthcare world where we have so many different data sources, so I think we have about 3,000 different hospital systems, 6,000 different professionals, provider professionals, more post-acute, 400 plus payers. The amount of data volumes out there are really tremendous. And what FHIR is trying to do from an interoperability world is, I think, a next step in our journey on how do we provide good care out there. Whether it's, version 2.0 of the High-Tech Act, I probably wouldn't call it that, just trying to drive the improvement in care. So with that, we're right at the top of the hour. I wanted to thank everybody for attending. Hopefully you found this informative. And as you drive your next steps in your strategies, we'd love to talk with you about how to make yourself successful in that. At CityTech, we focus on healthcare and the business of healthcare and really executing that through innovation and technology. So thank you very much and have a good rest of your day.
Thank you to our presenters for that wonderful presentation and for sharing your thoughts. And thank you to the audience for participating in today's webinar. This concludes today's presentation. Thank you again, and enjoy the rest of your day.